Blood trauma is an important topic. Being a surgeon, I elaborate more. As he said, definition: blunt abdominal trauma. Any trauma which is non-penetrating is blunt trauma. It is not necessarily, it may be the exclusive trauma. It may also be associated with chest trauma, head injury, limb injuries, other injuries. Abdominal trauma doesn't mean the the impact has gone only to the abdomen. The patient may also have other injuries to the abdomen, any forceful impact to the abdomen which is non-penetrating, that is blunt trauma. So organs, as the abdomen has, liver is the largest abdominal organ. So the commonest injury is liver injury. Spleen is relatively hidden behind with the ribs, chest cage. So splenic injury is relatively rare to the liver injury, but is associated with the impact on lower chest or flanks. But the other organs, they are also involved, like he said, bowel injuries. Small bowel injury is very common, and even in the small bowel, the common sites are the junction between fixed and loose parts, like DJ, ileocecal, and the most redundant part, mid-jejunum and ileum. Small bowel injury. Large bowel injury is relatively rare in blunt trauma. The pancreas is the most hidden and protected part. So the pancreatic injury usually in the blunt trauma is less common, but once it occurs, it is a very serious injury. It is always associated with duodenal trauma, small bowel injury, mesenteric injuries. So the impact when it has reached up to the pancreas, it is almost associated with the other injuries in front of pancreas, like small bowel, large bowel, omentum, mesentery, and even abdominal wall. So the kidney injury is very common. Kidney injury is very common. It is not always associated with hematuria. So urologist knows better. Kidney injuries, minor lacerations to even avulsions. For all organs, there is grading system. For all solid organs, like for liver, there are 6 grades, grade 1 to grade 6. We manage the patient according to the grades and condition of the patient and according to the associated injuries. For kidney, there are 6 grades. Or for pancreas, there are 4 grades. And mesenteric vessel injuries, they are also common. They are avulsion and lacerated injuries. They are most lethal injuries to the mesenteric vessels. The other organs, they are pelvic organs, like uterine injuries or diaphragmatic ruptures. Sometimes there are injury, sometimes there is excessive blow to the abdomen, and the patient is in deep inspiration or taken just meals. There is more pressure to the abdomen, so the diaphragm may rupture. Diaphragmatic injuries are also common. So patient presents with diaphragmatic hernia, gut inside the chest. So these are the organs involved during blunt trauma. Most common from liver, kidney, spleen, small bowel, large bowel, mesenteric vessels, diaphragmatic, and even other organs. So once the patient comes in ER with blunt abdominal trauma or RTA or any trauma, we start from ABC. We start from ABC, start from history. As you said, patient is conscious or not. If the patient is conscious, you can ask from the patient. If patient is not conscious, then from attendants or any person who brought him to the hospital. From the patient's condition itself dictates your treatment. Patient's condition itself dictates his treatment. Like patient is stable, we manage in a relaxed way. If patient's condition is in a critical condition, we utilize all our resources. We rush to towards the patient. We use all the resources. We start with IV resuscitation. We simultaneously start with all investigations we manage. So the patient's condition is important in the hospital management. So always start from ABC, ABCD. Most of the patients they have associated head injuries. Most of the patients they associated limb injuries. So we start from vital organs towards normal organs. Most of the patients, so it is a common topic for medical officers. They work in ER. What they do not follow the ABCD. What they do according to their attendance. डॉक्टर साहब इसका फ़ौरन एक्सरे करा दें. Most of the time what they do, they shift the patient to for X-ray for any femur fracture. In emergency, there is no role of X-rays. Start with ABCD. So what happens during this transfer to the X-ray? You get X-ray film. Patient comes back with more shock. Patient during this time, patient if there is associated liver injury, splenic injury, head injury, the patient bleeds more, and by the time patient comes back, he comes in more shock. Sometimes patient die in radiology department. So at that time, do not become panic, do not become worried according to the attendance कि वो मारेंगे कोई नहीं मारेंगे. You manage according to their protocol. If you follow the protocol, most of the attendants when they come, they are in panic, and when they see you are doing right for the patient, they realize and they go back. Instead, if you jaldi bhijwa dein for X-ray, he dies there, then it will create first we will lose a precious life. That is important. We will lose a precious life, then the medical, legal and other social issues. So treat according to the patient's condition. First you start from ABCD: airway, breathing, circulation. Now the protocol has changed. Circulation first. Get IV access. Attach your monitors, see patient's breathing, and manage accordingly. Get blood pressure and see do a second survey for associated injuries like limb injuries, second injuries like head injury, cervical injury. Cervical injury is the most neglected injury in ER. Even neurosurgeons, they neglect, they start what is GCS is 7, get CT scan brain. Even in all cases, in 10% of the head injuries, there is associated cervical injury. So always see for cervical injury. If you want to get the CT brain, and you always see the patient's chest, spine and abdomen. If it is hurry to get CT scan of brain, simultaneously you get CT scan of spine. Simultaneously you ask the patient to get CT brain, spine, chest and abdomen. If you are sending patient for CT scan and you are watching there is rib fracture as well, there is abdominal tenderness, it is when a neurosurgeon is saying you go for CT brain, you get all CT scan. Otherwise you stop, you do your examination, exclude abdominal injuries, exclude chest injuries, exclude cervical injuries, then CT brain. CT brain is not that much important other than resuscitation. Resuscitation first and do essential investigations. Essential investigations are fast scan and blood, lab and cross match. If you are sending blood, then do hepatitis profile. Not all other investigations, they are not primary investigations. They will lose your time. Like renal profile, it takes at least 1 hour. LFTs, it takes 2 hours. What do you want to see in LFTs? Even in liver injuries, there is no role of LFTs. RFTs, no role of RFTs. These are the investigations to be done in ward when the patient is admitted in a stable condition. So the primary thing is history, your good examination and your plan of treatment. Either you are doing urgent surgical intervention, or patient may have three conditions. One, you have seen, when you have examined, there are three possibilities. Number one, patient is stable. Most of the time I will just do stabilize the patient and patient will go home. That is scenario one. Second scenario is, I think this patient needs admission, some resuscitation. Once I will admit and then I will investigate further. I think this patient doesn't need surgery, but this is scenario two. If the patient may have required surgery, but it is not that much necessary. That is scenario two. Scenario three is, no, the patient needs immediate surgery, abdominal injury, chest injury, immediate chest tube thoracostomy, abdominal laparotomy, immediate. That means the patient is in critical condition, patient is bleeding, patient is sinking in the river. You have to bring the patient towards life. In this condition, you will have to rush. Now your reflexes will be totally different. Your reflexes will be resuscitation first and investigation second. So you start with IV fluid, IV cannula, IV fluid, good IV fluid, antibiotics, stabilize the neck and clear his mouth, give oxygen, attach monitor. Simultaneously you call your surgeon, surgical team, not only surgeon, your team. You are also part of surgical team. DMO is the main frontline pilot of this surgical team. Surgeon is at back. Your OT team and your lab team, your X-ray team, your radiology team, this all is surgical team. This all is resuscitation team. You involve all the people. Everybody will do his job. You send labs to the blood for the lab. Ask them bring the blood immediately. Do not go for the X-rays. Fast scan is not always necessary. Sometimes we do not even do ultrasound. Sometimes we do not do fast scan because the radiologists are not readily available when they come late. So the history, as you said, the patient has abdominal tenderness, rigid, patient is pale, patient is shocked. So the possibility is patient is bleeding in abdomen. If the patient is stable, you get investigation fast scan. If the patient is more stable, you can do CT scan. Fast scan to see the kidneys and type of injury. If the patient is stable, then CT scan level of injury. You can even grade 2, grade 3 liver injuries, grade 2, grade 3 renal injuries, splenic injuries can be managed without surgery. Now the role of CT scan is, if you are planning for conservative management without surgery, patient is stable, you can manage in ICU, then we go for CT scan to see the grade of injury, If the patient is relatively stable, then we admit, we do that protocol. If the patient is not stable, we can do management on clinical grounds or maximum fast scan. So the patient should be managed in ER. Doctor is always present, whole team is present. Do not make this habit to shift the patient to immediately to the operation theatre, because operation theatre we can do surgery, we cannot resuscitate, we cannot investigate. There is no lab facility in the operation theatre, there is no radiology facility in the operation theatre. If we have to go back for the fast scan, we will move the patient back to the ER or radiology. That will just lose more time. So do not make this habit. Emergency, the patient comes in the ER or even patient बाहर टैक्सी में होता है तो कहते हैं दौड़ाओ, फ़ौरन OT में दौड़ाएं. तो OT में there is a one OTA everywhere in Pakistan, in the good operation theatres, there is only OT team. There is not always operation surgeon or anesthetist available there. So this part of the treatment management should be in the ER. Now comes the surgical management. There is a different topic. laparotomies or even laparoscopic, what we do in the liver trauma, what we do in the splenic trauma, what we do in the renal trauma, that is beyond capacity of this lecture. So in ER we manage blunt abdominal trauma from history, your examination, then the patient falls in 3 scenarios. Scenario 1, patient is very stable, just there are lacerations in the face and some bruise. You excluded head injury, you excluded spinal injury, you excluded chest trauma. Then now you do a good investigation, like you get X-ray chest, you get ultrasound, and you see the spine. This patient needs some resuscitation, make him pain-free, stable him, attendants will come, then counsel him and send back. That is scenario 1. Scenario 2, the patient needs admission. Patient needs admission, but not urgent surgery. Not urgent surgery. See, there is some tender abdomen. There is some tender abdomen. There are ribs fracture, but patient has no pneumothorax, but no hemothorax. You admit the patient with your protocol of head injury, spine injury, chest injury, abdominal injury, limb injury, even fractures. You admit and stabilize. You get now good investigation, all investigation, blood complete picture, hepatitis B and C. Now you do blood sugar. Now you do RFTs. Patient may have previous renal injuries. You get LFTs. Patient may have previous hepatic issues. All investigations and get your surgeon in picture. The scenario 3 is rush. Patient is unstable, patient is bleeding in abdomen, chest injuries, head injuries. Move your all resources to save the patient. Do not get X-rays. I again say, do not get X-rays. Just you start with ABCD and save the life. Anything else अगर आप पूछना चाहते हैं तो?